Good morning or good afternoon, depending on where you are. My name is Ashley Mangum, she, her, and unfortunately, I am off of camera today. Of course, my camera decided to not work and my backups didn't work. So I'm going to be relying heavily on Jamie to be my facial expressions. And I often talk with my hands. So I'm sure she knows some of my mannerisms, but super excited to be here and be part of these conversations. It's always amazing to hear from other healthcare systems and communities about what they are experiencing and what they're doing. And I know we've been a part of several of these, and they almost feel like a support group at times, but it's amazing to know that we're not doing this work alone, and so much can be learned from each other through sharing these experiences and outcomes, and really what we can do when we work collaboratively to really strengthen our communities. I'm super excited to be here today also with Jamie Couts. Jamie, would you like to introduce yourself as well?
You bet. And you know what? I'm going to throw my hands around just to
Thank you.
represent for you as I do it. So my name's Jamie Couts. I'm the Assistant Vice President for Pediatric Behavioral Health at Multi-Care Mary Bridge Children's Hospital, and very much appreciate the opportunity to come and highlight this terrific collaborative initiative that's under Ashley's leadership. We couldn't be more proud of the work and of our community. And we think that it is highly replicable. So looking forward to sharing today.
Thank you. So what we really are going to be focused on is really telling our story and telling it from a lens from both a community perspective and a healthcare system as well, and how we've been able to utilize those partnerships to really create a community model that really is focused on bringing the community into the behavioral health continuum. I did see some of our amazing colleagues here in this meeting today, and I hope that you can be our co-presenters in some way and utilize that chat to share your comments and your experiences as well. But we really just wanted to spend this time in telling this story. And we again, just really echoing what Jamie says, think that these are some things that can be implemented into your systems and into your community as well. So Jamie and I both work for Mary Bridge Children's Hospital, which is located in Tacoma, Washington. And we really just wanted to ground this conversation in, what we know is happening across the country, but really talking about what also is happening here in Washington State. I'm sure, as many of you know on this call, we have been having a significant increase in the mental health needs for our kids and youth across our state. So much so in 2021, our governor actually signed an emergency proclamation that really expressed that there was a mental health crisis in Washington State. For many of us who have been working in behavioral health, this was not new for us. We think that the pandemic really highlighted the silos and the challenges and the gaps that we were experiencing. But for us, our conversation had started way before 2021 with the increased needs that we were seeing here in our community in Pierce County. As we continue to talk about those needs and we talk about the challenges that we were seeing, if you look at some of the data that we have in our screen, approximately 1 in 3 of our kids that are enrolled in Medicaid were not able to access the services that they were needed. And this is even less for our youth that are experiencing substance use disorders and needed those services. Fewer than actually 1% of those youth were able to access those services. One of the interesting things that happened for us in Pierce County was that we were seeing a really significant increase in the amount of kids that were coming into our emergency department for a behavioral health chief complaint. And I always kind of think about, I believe we became kind of our pseudo crisis facility in Pierce County because of the trust that Mary Bridge had in our community, and oftentimes parents and community providers not knowing where to go and where to send these families. And when I talk about a significant increase between 2015 and 2018, we actually saw a 400% increase in the amount of kids that were coming to our hospital for a behavioral health chief complaint. And one of the things that we've had the opportunity to learn as we've done a deep dive through these charts and having conversations with parents and youth is a lot of times families are coming to the emergency department seeking services that are not available through our emergency department. We're often not able to start a youth on medication, or if they're expecting out-of-home placement or respite, that really is not something that's achievable through our emergency department. And so it was really important for us to know that, and also to learn that even when people are coming to the emergency department for these services, they're still not able to access access the transitional services that they need to be connected into the community, right, for the right level of services. And so this data was really helpful for us to really help navigate those conversations, to really know where some of those gaps were, and to really advocate, knowing that communities are affected disproportionately. We know our youth that live in rural communities might be disproportionately affected. Our African American and BIPOC communities, LGBTQIA plus communities as well. And so really being able to understand that and being able to really have a good understanding of what was working in our behavioral health continuum and really what was needed. Jamie, is there anything that you want to add to that at all?
No, I think that's great.
All right. So as I mentioned, for us, prior to my role here, I actually was an emergency department social worker at Mary Bridge. And again, when I first started in our healthcare system, I had a position where we only needed one social worker who could work our adult ER as well as our youth ER. And that significantly had changed over the course of a very short amount of time. And our journey into this process of really bringing the community into the conversation started in 2017 when we had a youth that had a really complex presentation end up in our emergency department. To give a little bit more information about that, it actually was a youth that wasn't from our region. He was actually placed in what we call a developmental disabilities administration home. And unfortunately, they were not able to manage his needs. He had co-occurring diagnoses. He was nonverbal. And it really highlighted the complexities and challenges that existed at that time in our pediatric behavioral health system. And from a healthcare lens, it really highlighted the challenges that we had in navigating that. For our system, it resulted in multiple staff injuries. It resulted in hundreds of thousands unreimbursed expenses. And as a social worker who worked in the ER at that time, it really had a significant moral injury on our team when we come to work every day with the goal and the value of helping our patients and not having any resources to help this youth who thrives on predictability, on structure, on routine, and one of the most unpredictable environments, where this youth spent over 6 weeks in an emergency department, where we cannot provide that level of consistencies. And it really, again, at that time, really highlighted those silos and challenges, but also then creating an opportunity to say, what can we do? We know in Pierce County, we have a really rich history of being able to collaborate around things like this. We've seen it happen successfully around domestic violence and child abuse with the development of child advocacy centers. And so we really wanted to say, what can we do? And Jamie, I know it was your incredible leadership around this time, and I would love to hear from your perspective too about kind of some of the conversations and vision that happened around these times when this event happened.
Well, I mean, I think that this kid, that this is what captured the attention, right, of a larger system. So it wasn't that the volume that we were seeing in the emergency department was going unnoticed, but this certainly raised the alarm as we began to, as staff were injured, as time marched on. I mean, in some ways now I look at this and I think, oh, 12 weeks in the emergency department. We have subsequently had kids that have been with us for a year. So in some ways I'm like, oh, what little did we know what the future would hold. But this allowed us to really go to our executive team within multi-care and say, this case encompasses all of the challenges that kids, families, and our teams are experiencing. And it's really quite a positive reflection on our executive leadership that they listened repeatedly, and that they made investments so that we could create change for kids and families.
Thank you. And I think it also, for me at the time as a social worker, again, really highlighted the need for developing that coordinated response. And I think it became very clear to us of what our limitations were as a hospital and how do we create those collaborative partnerships, knowing that many of our systems are working towards the same thing. Many of us want the same things for our kids, and that's to be safe and well in their community. And how do we leverage what we do have and what some of our challenges and barriers are to have the best outcomes for kids? I love this visual here today with the hands all in, but oftentimes when I do this training, I have that meme where it's Spider-Mans and all these different costumes who look the same and pointing at each other. And that's often how it feels when we talk about cross-systems collaboration, right? We say, it's not me, this isn't behavioral health, this is a child welfare issue. This isn't a child welfare issue, this is a juvenile justice issue. And what we really found out through this experience is that it's a community response, and it's all of our kids. And you don't have to be a patient at Mary Bridge for us to be a part of your care plan, a part of prevention, and a part of the conversation. And it really was clear to us that no single system was going to be able to remedy the complexities that we were seeing, and really being able to bring all of our community partners together to identify a plan of how we can work together moving forward was going to be our best approach to be able to manage the complexities that we were seeing. If you have not had the opportunity to read the U.S. Surgeon General's advisory on youth mental health, I highly encourage you to do so. This is a visual for me that really encompasses why we have to get out of our siloed approach and really bring these other levels into the conversation. Oftentimes when we work with our patients, we're able to maybe, work directly with the individual and sometimes the family. But a lot of times, and what we've learned through our deep dive and looking at some of our data, is so many of the complexities and the risk factors that are contributing to their presentation expand beyond that, right? It has to do with their community, not having access to their needs in the home, their environment. What's the culture like at school? What are their relationships with their peers and their teachers? And as we continue to have these conversations and pull youth and parents into the conversations, often we found what was contributing to their behavioral health crisis wasn't clinical at all, right? It had to do with their family of origin and our conflict in the home, our bullying at school. And so what we also learned was the intervention also wasn't always clinical. Through a lot of our conversations, what we found out was sometimes this kid needed a bed. They needed an adult to hear them. They needed to have more presence at school. And so being able to have all of these different systems and levels and partnerships that can really speak to all of the different factors that shape mental health of young people is very, very critical in developing a response that really doesn't leave your hospital as the end responsibility, but just the landing point for navigation back into the community to support their youth after they leave the walls of your hospital. So for today, we wanted to just give you a little bit of background of how we use those experiences to really develop a community coalition that has been really working towards developing a coordinated behavioral health system. And it's been very, very phenomenal to have a hospital system, Mary Bridge, as the backbone organization, because it's really allowed us to create collaborative partnerships that allows for great data and information sharing that I don't believe that we would be able to have had we not been a part of that conversation in the backbone organization. So after we had that Sentinel event in 2017 and had the conversations about what can we do, the vision was to facilitate our first ever Children's Mental Health Summit in 2018, where we brought 75 community partners from all over Pierce County together to have a conversation about what are you seeing in the community, what are you seeing through your organization, to have a conversation and have a really equitable and diverse lens of what was happening all across our region. And it was really important for us not to come to the conversation to say we're really concerned about the increased numbers of patients that are coming to our hospital or the amount of boarding, but what is the larger conversation about what are happening with our kids and families. And I believe through that shared conversation where we were an equal partner at the table and facilitated and not the implementator of what we were going to do, it really helped us to develop a shared understanding of what the issue and perspective was. So it really allowed us to land on what we wanted to prioritize as a community to be able to address those things and really focus on those things early on that didn't require a large financial investment, significant policy changes, but things that we can achieve as a community just through community agreement. Jamie, is there anything that you'd like to add to that?
Yeah, I mean, I'll just piggyback on that when I said, at the outset that I feel that this is a replicable effort. I mean, basically, what this is, I mean, we've got slides and we've got data and we've got all kinds of good, bells and whistles. But really, what this is was a conversation. That's what this work is. It is a community conversation, and while it's true that it's helpful to have a convener, and in this case, Marybridge Children's Hospital is the convener, that the collective energy of the community is what makes this work. And backing up just a little bit, before we held the summit, we sat and just cold called. I mean, we had lots of relationships with people, but there were also people that that were new to us. But we called everyone that we could think of in the schools, everyone that we could think of in other healthcare systems, everyone that we could think of in child welfare or juvenile justice, or in just community-based organizations or nonprofits, anybody who had any sort of link to kids. We called those folks and just said, what do you think, right? What are your concerns in regard to pediatric behavioral health in this community? And at that first summit, right, we had people all the way from, I think we had representatives from a NICU all the way up through, kids that were about to transition into young adulthood. So we really did have the spectrum of participants who had concerns about kids, the well-being of kids, particularly as it related to their mental health and their emotional well-being.
And I would just add, I think one of the great things that happened in forming that first summit was the engagement of leadership level participants who could make decisions and inform their agency and make commitments, because bringing the community together does require some resources and some commitment. When we have these monthly meetings, what is the benefit to the organization by having their staff attend every single month? And so that's why it was so great to organize in this way where it was really community agreement. And for our community, we really focused on wanting to improve our access and care coordination, bolstering our youth mobile crisis services, ultimately with having a family wellness center in our community that would be that one-stop shop for all things behavioral health, and then the workforce to support that. And we, through all the lenses of the different organizations, those were 4 priority actions that were important to all of them. And so that really helped us create that mutual buy-in and those shared goals. And it really helped us be able to identify measurable strategies that we can come back in a year and say, we already have a win. We already have a website and a landing page. We have action teams. We were able to really create some really great outcomes because, and I couldn't appreciate the timing more because little did we know a year later we would be in a global pandemic. So it was absolutely amazing to have the foundations, the relationships, the priority actions for our community already identified, so that we can continue to mobilize and move forward, even in the midst of a really challenging pandemic. So again, for us today, I really wanted to not only talk about from the community lens some of the great outcomes, but also some of the hospital strategies that could be helpful in thinking through from your own organization. And before I turn it over to Jamie, I've had the unique privilege in this position to really be kind of the liaison between the different sources of information, whether it be parent family, our state, our local legislation in the community, to really have conversations with our hospital partners about maybe a new policy that's going to be implemented that might impact our hospital system with the involuntary treatment laws changing, or our family initiated treatment laws changing, and how do we get ahead of that and prepare our system ahead of time so it's not a crisis, or being able to do surveys in our community to see about what their experience is, or having positions where we're able to review charts and really get a better understanding of the data, and why people are coming into the emergency department and why they're being discharged. And so all of those partnerships have really allowed us to gain the best access to information to help us have an informed system response. And so I'll turn it over to Jamie as one of our amazing hospital leaders to talk about her experiences in some strategies that we've identified today.
Thank you, Ashley. And I'll talk about this specific to hospital settings. But again, if people are hearing this presentation and thinking about that it might be useful in their own communities to start a conversation about how can we come together as a group and have some shared agreements and some shared goals for the youth in our community. I think that these strategies would apply to anybody who was considering sort of being a backbone of this or a convener of the conversation. So, and this first one, engaging your internal leadership and encouraging a multidisciplinary approach for folks who are working in hospitals or have familiarity with hospitals, you probably are familiar with folks questioning, why are these kids in our emergency department? Particularly if you are, Marybridge does not have a psychiatric emergency department. We are a medical emergency department. We're a level 2 trauma center. And so there is, as we were seeing these increasing volumes, there was a lot of conversation, a lot of questions about, well, this isn't the right place for kids. And while, by and large, we would all agree that we want kids to receive services close to home and in a way that's comfortable to them, and that the emergency department doesn't necessarily fit the bill every time. At the end of the day, for many communities, emergency departments are where kids and families need to go, because that's the most expeditious. It's what they recognize. They view it as safe. And so helping your leadership understand that the perception of the community, and that it's not always a terrible thing, right, for your community to believe that your emergency department is a safe and welcoming environment for kids who are experiencing a behavioral health crisis. You should be proud of that reputation, and I think the more education you can provide to your professionals within your organization that may not be attached to behavioral health, the better off you are. Using data to inform and dispel misconceptions or misinformation about behavioral health needs. We do spend a lot of time providing education to frontline staff and to leadership around, this is a presentation, this is what it entails, and also, because, and I'm sure many of you have had these conversations where people say, well, why can't they just go to such and such? Why isn't there a bed, or why isn't there a residential facility, or why isn't there a place that's more appropriate for this child to receive care? And to provide education around what is available in your community, what's available across your state, the work that's being done to try to advance more services, more placement, et cetera. People are surprised. We have had experts come in and provide town halls that we record and then we disseminate to every single employee across Marybridge, so that everyone, if they are so inclined, can listen to sort of the state of the union, as it were, in regard to services for behavioral health patients. Was also important for us in our conversation with the community. Most people in the community, whether they were agencies or individuals, would say, well, we thought that if we came to the hospital, that the hospital had sort of the secret squirrel resource, that you had a back door, that you had a way, that the hospital could make it happen, that you had the power to create outcomes for kids that we felt that we didn't have in the community. And so I think it was very important to level set with folks so that we all understood our vulnerabilities, and that in working together we could likely overcome many of those, but as individuals it was difficult. So that gets into, reaching out outside your system walls to understand what's happening in your community. I mean, basically, I feel like I think you're getting the theme here, that it's talk, and then maybe talk some more, and then you could talk, and then you could have another conversation. I mean, that really is the crux of this work, right? You are talking to folks in your system, you are talking to folks outside of your system, you are staying informed about what's happening at a state and local level. And then from those conversations, you are talking internally about the protocols and the workflows that support this work within your organization. This is particularly germane to hospitals, right? Because this is a new arena for many folks, and a lot of emergency departments are like, well, we're not used to having, for example, an activity cart that has activities that are organized according to colors that are permissible for kids who might be engaged in self-harm behaviors. So we've had to develop all manner of protocols and workflows to be able to accommodate kids, ensure that they are comfortable while they are staying with us, and that the work that we're doing with them in our emergency department is supporting them as we work toward a disposition that will result in better services for them. This last one, recognizing, calling out, and developing a plan for recovery to address moral injury. This is many gold stars to Ashley for calling out this work, for initiating a plan, for engaging subject matter experts, and for organizing teams around this information. I can't. It doesn't matter what meeting I go to now at Multi-Care Mary Bridge, somebody for sure is going to mention the term moral injury, and they are going to mention it in a contextually appropriate way. So just raising awareness and then providing education and resource around this is really helping us with staff engagement, staff retention, and it is also contributing to our community conversation. Ashley, do you want to say anything more about moral injury?
Yeah, I got to hear in our last presentation, I think there was a question about how are we maintaining our staff? And I think that this is one of the most important conversations we have to have about maintaining our workforce and supporting our staff, particularly, for me, when I hear so many conversations, this is a new thing to them. And oftentimes I believe it's not it's a win when we have that patient that is in front of us that we have called 100 beds and it's a decline, and we're all working so hard to be able to support, and having an understanding of what moral injury is and being able to recognize it, and then also being able to identify what are your internal and external resources for your teams to be able to support them through that has been absolutely helpful of creating forums for discussions and really talking about how these are having impacts on our systems and how we can avoid these things so that we can maintain the well-being of our teams that are doing really hard work. I also just want to give some really easy examples of things that have happened just with these strategies. I just think about when the pandemic first happened and we were seeing kids coming into our emergency department, and we had learned our youth mobile crisis teams weren't going into homes because of the pandemic. We were able to engage them in a conversation where one of the barriers was they didn't know how to use PPE properly. That was their fear. And so our Mary Bridge nursing team met with our youth mobile crisis providers and provided them training on PPE. That was no cost to either our organizations. It was through those collaborative conversations about how do we support that need and what resources that we have that exist. I think about the monthly data that we capture every month and for sharing. A lot of times when we talk about our behavioral health patients experience, our volumes, it's a lot of times how people feel about it. Like, oh, I feel like it was a really busy week. And so when we can actually drill down to the numbers and have some comparison to show this is kind of our average rate, or this is what we usually reflect on an annual basis, I think is really helpful again in helping to dispel those misconceptions and misinformation and really get to what is happening and how do we support those identified needs. So it's been a collaborative process both ways, and also learning from the hospital has helped our community and being able to advocate for other levels of services, such as getting a non-Medicaid wraparound team funded through our community and having other services funded that didn't exist to really help expand our continuum of care here in Pierce County. So I think working, both ways, thinking about kind of that internal and external response. One of the great things that happened from our first summit is that we agreed that we were going to work together as a community to really address those growing needs and to also create a streamlined, coordinated system of care for school-age kids here in Pierce County. And so in 2018, we agreed to form a community coalition at that time that Mary Bridge Children's would serve as the backbone. And I was brought in 2019 as the project manager for that. And it was really interesting at that time to have a 1-year offer for a position. And I could always go back to the emergency department to it now being a legislatively funded model that we are now working on implementing across our entire state. But this picture here is one of our first action team meetings where we really asked again our community to come together and focus on what bucket of work they wanted to prioritize. And we really, continue to work as a community coalition. We intentionally do not brand it as a hospital response. We want this to be owned by the community and reflective of what's the need and how it's implemented and served into the community. And again, we really have a intentional and we really work hard to have a equitable and diverse representation of Pierce County, because we have very rural communities, we have very urban communities, and what works in one part of our county we know won't work in another county. So we really work hard to have representation from all of our various cross-systems partners, and it's always amazing to get those new connections and somebody being introduced. And we've been really helpful in integrating new service providers into our regions by providing them a platform and a forum to share information about their services and how they can engage. And I was in a presentation yesterday and I was like, I hope that one day we can change our language from even saying that we're having systems collaborations, but we're really having community conversations, right? And being able to remove system from it, where we're really building relationships, where I'm not having to call child welfare system, I'm calling this individual that I have a relationship with to talk about this youth specifically. When we talked about early strategies, again, for kids' mental health Pierce County and our desire to really have improve our access and care coordination and really have a family wellness center or a brick and mortar building that would serve as a facility, we really had some conversations about what that could look like without the physical structure of a building. And one of the most amazing resources that we came up with as a community was the development and implementation of a community multidisciplinary team meeting. And if there was one thing that I would recommend that you consider implementing into your healthcare settings, or if you were to look at, would be the development of a community MDT. And these are helpful in so many different ways. It's one of the few settings where you can take into consideration HIPAA, information sharing, care coordination, also FERPA with our school districts, and really being able to come together with various partners to really help youth. In our community, we've created a process where anybody in Pierce County can request a community multidisciplinary team. We have an amazing program coordinator that reviews those requests. And because this was developed in collaboration with our community partners, we've developed a really clear scope of what the functionality would be of these community MDTs and how we convene them and why. And so it's been amazing to see the continuous support from our community partners around these community MDTs, where we can within 24 hours convene sometimes 20 to 25 partners to really talk about youth and their needs and how we could support them. I would say one of the most powerful things about convening this forum is even if we don't land on agreement about what the clinical information should be or what the next steps are, what we often hear from our parent partners is that they have never had this many people come together for their youth and family. And that for me is an outcome in and of itself, for no family to feel like they have to walk alone in navigating our really complex behavioral health systems. And we know that that tends to be our response oftentimes, that we are handing families a list of resources or numbers and saying, good luck. And how do you navigate this? And this has really created a space and a forum where we are wrapping our arms around families to be able to really navigate their needs. And it's really identified about who from the family, who participates, what they need, and really bringing in our other partners to seeing how we could support that. I just want to leave you with one example of a power of a community MDT and how they're so impactful and can be used. We had a youth that I kid you not, within the span of a couple months, had literally cycled through every system you could think about. He had multiple ED presentations where he didn't meet criteria for acute inpatient hospitalization, so he'd be discharged back to parents in the community. The parents eventually identified that they were no longer able to care for this youth, and so unfortunately he ended up in the child welfare system, where he was placed into protective custody and placed into foster care. Unfortunately, while in foster care, he ended up assaulting someone. And unfortunately, from there, he ended up in the juvenile justice system, where he ended up in our county juvenile detention center. And at that time, we decided to convene a community multidisciplinary team meeting. We had a bunch of community system partners and providers, but we also invited the school. And this school person had a connection with this youth, knew this youth very well. And what we learned in that conversation was that youth was really struggling with no longer having in-person learning. It was during COVID, and it was when kids had transitioned home. And that school partner was able to advocate for that youth to have some in-building time. And we have not seen that youth since. That is not a recommendation that I would have been able to make as a clinical social worker. That's not something our WISE teams or our behavioral health providers could have recommended. That could have only came from the school, and that recommendation could have only happened by having that school at the table. And so, as I mentioned before, not always is the intervention clinical, but it is really about us creating a safety net and bringing the resources that do exist to our families to create that safety net for when they need it the most. And I think the overall goal that we've come up with through these forums is we really just want to make sure that our kids have access to the right service at the right time and as close to home as possible. One of the second things that we also wanted to prioritize was our access and care coordination. And part of that too was really streamlining, coordinating our behavioral health resources in Pierce County. Again, we always have a lot of different resources that are floating around in our community. And we know that there's so many factors that just drive access, whether it's insurance or age or what type of services that you're needing. And so we're able to agree on a landing page, and which became a website that really has a great amount of resources for all things kids mental health in our region, where providers are able to access this. You have access to our QR code, and we can put that website in the chat as well. But I highly encourage you to look at the website. It's really helpful. We've had things like webinars on there, information on how to navigate insurance. And again, we've made this a community resource. So there's a community calendar where we're highlighting new providers and services, and it's updated in real time. You know, one of the most powerful quotes I've ever heard from a parent is, we don't need another door to an empty room. And that's what we do when we're providing misinformation and outdated resources to our families. And so our commitment to keeping that up to date as possible and really helping parents again navigate those resources are really important. Even on our webinar topics, you know, we really plan them around what's identified by the community. So we've had webinars from talking to kids about racism and social justice to how to transition back to school, and really in real time, and what's needed from our community partners as they're trying to support our youth and families the best that they can in our community. Jamie, anything you want to add to that?
Just encourage everybody to go to the website. It really is the best. I realize I'm a little bit biased, but it's killer. It's great.
And I'll say too, I think one of my favorite things that I see is, you know, through community agreement, again, we'll now see doctors putting this website in their discharge paperwork. I'll get an email from a school counselor and it's in their signature line. And so that community agreement to say, if I think of any other place, I'm going to send them to Kids Mental Health Pierce County, because I know those resources they'll be able to reach out to us through the website and we can support. But those are things, again, that just happen from community agreement and being able to build those relationships. So just before we open it up to any questions and answers, again, I really just wanted to share just some of the outcomes from different, viewpoints of how this kind of work and really bringing the community into the behavioral health care continuum in your community can be really impactful, not only from your internal systems, but from the community collaboration, and just all of the things that can happen through this level of partnership. So when I think about our community, we've been able to stand up a youth crisis collaborative that's really focused on our youth mobile crisis teams. I know there was a question about that earlier. And one of the things that we've been able to use is the conversations and the advocacy from our implementation teams we now have 2 county providers instead of 1 that we used to have before. And so we've really used our voice to inform what is our crisis protocol in Pierce County. How does that work? We've been able to advocate for our crisis teams to be co-located at the hospitals, to be able to reduce response times so families aren't waiting 8-9 hours for that type of discharge plan. We partner with them often to do community trainings to really get that information out into the community, because that's something that we know a lot. We live in a region where we have a 24-hour crisis team, and we're wondering why aren't families using them, and a lot of times it's because they don't know. So we're really doing a lot of work with our partners to be able to get that information out into the community, because we really believe that that's the best environment for our youth to be served at. We've also been able to create some really innovative programs. We have a school-based program to really support behavioral health navigation and brief intervention. And again, this information and these programs have really been built around the data that's gathered through Kids Mental Health Pierce County, what we're learning is happening at Mary Bridge, and being able to advocate for that for funding streams, whether it's our county or our state funders, looking for grant opportunities. And it's really been successful in filling in some of those gaps and being able to serve kids regardless of insurance. From a hospital system, we've again been able to advocate for unique FTE positions such as behavioral health navigators. We were able to advocate for a social worker that just manages our detained patients, our long stay patients, and that's really helpful for care continuity and really impacting our length of stay and discharge plans. And again, we've been able to engage our community partners on a statewide level to talk about how this can really focus on the now and bringing that into other regions to make it unique to theirs. We don't talk about this as a replication. This is an opportunity and a model for them to bring into their own unique communities to find out what works for them and how they could best leverage their community partnerships to really have an impact on their behavioral health system in our communities. So these are things that can happen. I know we talk about some of the challenges and we kind of focus a lot on what we can't do, but there are so many opportunities for us for what we can do. And while we're creating systems and we're building facilities and we're extending our workforce, we know that's going to take time, but we can do something today as a community and really focus on what we can do to support our kids and families and what resources do exist. So I will open it up for any questions. Jamie, did you have any closing words of wisdom?
I don't think I do. I think you did such a great job. Again, it's conversation and community accessible to most folks. So I'm hoping that this spurs a phone call or two to somebody that you know across town.
Me too. Thank you both again so much. I absolutely love the deep community engagement, community up approach. As I've heard about it over the years. We do have a question in the maybe we have 2 questions. Okay. One is some clarification on the differences between a community multidisciplinary team approach and a system of care approach using wraparound services.
Yeah, absolutely. That's a great question. And we've been doing a lot of conversations here in Washington State around what some of those differences are. And so in Washington State, not all of our youth are eligible for WISE services. That tends to be only eligible for many of our regions for Medicaid eligible only youth. And so what this does is this is a really unique opportunity that's eligible to anybody in our community. Our community partners are different about who sits in on that. We have community partners with expertise from all over disciplines. You know, we've had psychiatrists and psychologists, we've had their pairs on, we've had the school districts. And so it really is dependent on the scope of the need and what the ask is around the community MDT. We also do partner with our existing like WISE providers or wraparound providers to determine if this is the best forum. One of the things that we do is keep families at the center of this. We don't want families having to tell their stories in multiple forums and with all these various providers. So we really work with them to make sure if this is the best forum for them, and if not, how do we support that youth?
Right. Thank you. So the other question is, what training and experience do your behavioral health navigators have? What's the
Yes.
for them?
Great question. So all of our behavioral health navigators are through our youth engagement services program, and they are master level clinicians. So we have social workers and other clinical levels. And so the unique component of our behavioral health navigation is they have the clinical background where they're doing the assessments to determine if they only need behavioral health navigation. So really identifying if it's a low, moderate, or high level risk, or there's a identifiable need that requires treatment, and being able to either help connect them to the right level of service in the community or provide brief intervention for them with the intention of getting them transitioned to those levels of services kind of based on what their needs are and what those are. So our program is a little bit different. Jamie, I don't know if you want to add into that in any way.
No, I mean, I think that that's an important distinction because this program is designed for if you come into the emergency department, our first slide, the gap between if you're seeing an emergency department for a crisis and when you get into services in your community, that can be a substantial gap. And what we didn't want to have happen was, kids and families floating out there for an unforeseeable amount of time as they're trying to navigate the system independently. So we wanted to have somebody come alongside that would assist them with getting into the right place. But if there was a wait and there was clinical work that could be done, then we wanted people who were qualified to do that work. And they do it in the community. So they'll do it in the home, they'll do it in the school. And it's 90 days of navigation and intervention. And 90 days seems to be about the right amount of time for folks to either transition, or maybe we've gotten to a place where the primary issues have been ameliorated and folks are ready to and don't feel that they need services at that time.
Thank you. Okay, Chip, last question. We'll be at the end of time.
So Chip Schreiber, Rapham, Mental Health, Harbor, UCLA. My question is, there's some data emerging after the first year of 988 that many adults, at least, are sufficiently served by relatively brief telephone contacts, such that the crisis, at least at that moment in time, maybe not longitudinally, is resolved, so they don't even need transport by law enforcement or EMS to those overcrowded EDs. I guess I'm wondering, what's your experience? Do you have anything similar to that emerging data out of 988? And where's 988 fit into Pierce County? Thank you.
Well, yeah. I think Ashley, let's tag team this a little bit. So 988 is present in Pierce County, and I think that we've had some geolocation issues, but I think that those have been addressed. Ashley, correct me if I'm wrong. I had heard that those were resolved. Is that correct?
No, that's not correct.
Okay, see, this is why you have Ashley first, then Jamie. So, so I'll defer, Ashley, if you have more to say about 988, but I do want to talk a little bit about uh, our team's data pull and our experience then of why kids are in the emergency department, and how, to quote my 91-year-old mother, using a shotgun to shoot a sparrow is probably not the best, not the best approach. So Ashley, did you have more to say about 988?
Yeah, I think this is why it's so important for us to have youth focused conversations, because the youth crisis system is so different than the adult crisis system. And so really kind of looking at, who is calling for youth in crisis, whether it's the individual youth, oftentimes it's the parents, it could be a teacher. And so particularly in regions that have mobile crisis response for youth, adding 988 has been a bit complicated because it's another level of somebody you have to interact with before that team is dispatched. So we have been having some local conversations, and it's been really helpful with our behavioral health administrative service behavioral health organization who manages those crisis contracts. We actually had a conversation with them today with 988. And so really talking about how those regional experiences happen to better inform those processes has really been helpful, because what we're hearing on our end is, it's not helpful for a parent in crisis to call 988, then be rerouted to our local crisis line, then be rerouted to our youth crisis provider, then get a response, right? So by that time, they've already hung up, called 911, and they're in the emergency department. So we're really trying to have those conversations. Again, great intent, really helpful in that continuum. But how do we make it helpful for the consumer that needs that more immediate response and that crisis response for our youth?
Which plays into to your point, Chip. If people can have the conversation, what we find is, so 80% of the children that present to our emergency department in crisis are discharged home. And they are discharged home, not necessarily with, hugely complex plans, but by the time they've come, we've done a full mental health evaluation, talked with mom and dad, done all the things. Everybody is feeling much better. People are feeling much better, and they've developed a safety plan. Maybe they've phoned a friend. They have, developed sort of a sense of connection, community, and they're feeling good to go home. And the vast majority of those children then don't present again to the emergency department. So it really does beg the question of, can we, either via 988 or whatever our crisis connections are in our community, how do we make that, how do we hardwire that, make it more accessible? Because right now, for many families, and I totally understand it, that if things have reached sort of a concerning level in your home, it's hardwired into us to call 911. And our 911, our first responders, they are hardwired to transport to an emergency department. So how do we hardwire in, again, not to, beat a dead horse, but how do we hardwire in the conversation so that people have somebody to talk to and create a different experience for their kid? Because it's hard to come to the emergency department with everything that's going on and tell your story. It's just really hard. So we want kids' first intersection with the behavioral health system, their first crisis experience, we want it to be, like a little hug. We don't want it to be, your spice scrubs and security sitting outside your door.
Thank you. We are out of time. This has been amazing. I really appreciate both of you and all the work that you're doing on behalf of kids. Can't tell you how amazing I think